Welcome to Respiratory Motion's general overview of minute ventilation and the ExSpiron Minute Ventilation Volume Monitor. The ExSpiron Minute Ventilation Monitoring System is an objective tool to help improve clinical decision-making at the point of care without disrupting current daily workflow of the staff. The ExSpiron provides a direct, real-time, quantitative measurement of breathing and is the only monitoring system available that addresses the national guidelines for depth of ventilation monitoring in a non-intubated patient. The ExSpiron measures ventilation and not just respiratory rate or oxygenation. Respiratory compromise is more than hypoxia. Elevations in CO2 can lead to acidosis and organ dysfunction. Failure of lung expansion can lead to atelectasis, inflammation, and pneumonia. Very few patients have a primary problem with oxygenation. It is usually a problem with ventilation. When you use real-time monitoring of minute ventilation, you are provided rapid assessment of patients' respiratory status, allowing clinicians to make immediate changes to the patient's course of care. Cardiac standards of care have advanced because of the ability to monitor in real time parameters provided by an EKG. An EKG shows early signs of cardiac problems that would benefit from treatment, and by watching changes in the EKG, you can also follow the effects of a variety of therapeutic interventions. Like T waves indicating myocardial ischemia could then be treated by nitroglycerin or stenting or coronary bypass. Or in a different example, an EKG can demonstrate specific arrhythmias and the effects of antiarrhythmic medications, or cardioversions can be followed. The ExSpiron is like an EKG for respiration, providing continuous real-time information. And most importantly, it provides an advanced warning with few false alarms. So where do we start? Can one look at a patient and know if they are at risk? With a deeper look into their medical history, does the medical history really help? Does the stop, bang, or prodigy score actually risk stratify patients in a meaningful way? Are any of these scores really useful for that specific individual? What can we rely on as clinicians to help us identify this particular subgroup who might be at most risk? Respiratory compromise can happen at any time and in any setting within the hospital. Recently, respiratory volume monitoring using the ExSpiron has become available for use throughout the hospital. It is continuous, non-invasive, accurate, and easy to use. It can measure minute ventilation, which is all of the air that goes in and out of your lungs in a minute. It is the fundamental unit of breathing. Dating back to Hippocrates, we have been able to look at a patient and see if they're breathing. But further clinical assessment is very subjective, like is the breathing shallow or labored? Blood gases, which are invasive, only became available in the 1970s. Pulse oximetry was introduced in the 1980s, and we thought it was going to be the answer to preventing respiratory failure and arrest. But as it turns out, it's a late indicator, so it only alerted staff when the patient was far down the spiral toward respiratory failure, and it has also been plagued by many false alarms. This has been especially a problem on the hospital floor with alarm fatigue. Capnography provides a measurement of carbon dioxide and respiratory rate, all in an attempt to assess ventilation status. These each have failed for a variety of reasons until now. ExSpiron's respiratory volume monitoring is quantitative, continuous, easy to use, sensitive, reliable, and is an early warning system with low false alarm rates. Changes in minute ventilation precede other secondary measurements, When someone stops breathing, then over time with metabolism, carbon dioxide values rise. Sometime later, oxygen saturation levels fall. If the patient is receiving supplemental oxygen, those oxygen saturation levels fall even later. The ExSpiron has been shown to identify low minute ventilation an average of 71 minutes before the oxygen level falls in a large study that was conducted at Mass General Hospital. ECRI is a well-thought-of group that assesses technologies and products for hospitals. It's like the Consumer Reports for medical devices. There are over 3,000 hospitals that look to ECRI to help them make choices between available medical products. Going back to 2016, ECRI evaluated monitors for detecting respiratory depression. They did not look at pulse oximetry because its data is provided too late. They did not look at respiratory rate because the data was found insufficient. They also did not look at any device that did not report information to a central station. This was an attempt to preclude alarms that went unheard. So only 3 devices even met criteria for being evaluated: the ExSpiron and 2 capnography systems. The ExSpiron Minute Ventilation Monitoring System was the only product to be awarded 4 stars. The others only received 3. The ExSpiron provides early, actionable, and accurate data in real time. Did you know that monitoring respiratory rate alone misses 80% of respiratory compromise? When the ExSpiron alarms, it is actionable, and there are very few false alarms. When you use the ExSpiron, this can reduce to reduced alarm fatigue for clinicians. Monitoring patients with the ExSpiron provides the earliest and most reliable indication of changes in respiratory status at the point of care. The ExSpiron detects early respiratory decline to enable earlier intervention. While we have been focusing on failure to rescue, the ExSpiron provides a way to be proactive instead of reactive, and for the first time, helps clinicians avoid the need for rescue. In several clinical studies, minute ventilation has been shown to be a much earlier indicator of change in respiratory status. Averting respiratory failure through earlier detection can reduce catastrophic events, improve patient care, improve patient outcomes, decrease healthcare costs, and save lives. When compared to a gold standard diagnostic spirometer, the ExSpiron has been proven to be both very accurate and reliable in both adult and pediatric populations. In this Massachusetts General Hospital blinded observational study, 259 PACU patients who had undergone elective joint replacement surgery were monitored using the ExSpiron. The findings are as follows. 92% of recorded pulse oximetry alarms were considered to be false alarms. Since the study was blinded, the ExSpiron alarms were turned off, but the data showed that repeated low-minute ventilation alarm criteria began an average of 71 minutes before true desaturation measurements were recorded by pulse oximetry. Subsequently, patients who experienced low-minute ventilation alarms had a 1-hour increased length of stay in the PACU as compared to patients with adequate minute ventilation throughout their stay. Here is a study of 48 non-intubated subjects where changes in capnography measurements were found to poorly reflect large changes in minute ventilation, and the changes observed, the end-tidal CO2 measurements, were not considered to be clinically relevant. Minute ventilation measurements changed more rapidly and by a greater degree than capnography could capture in response to respiratory changes in these non-intubated patients. In another study conducted at the Mayo Clinic, 107 PACU patients who had undergone abdominal surgical procedures were monitored. Only the ExSpiron identified patients that were at risk for respiratory compromise. Using respiratory rate alone missed 80% of all respiratory compromise. None of the standard demographic parameters or pre-op scores predicted respiratory depression. Only moderately lower minute ventilation prior to opioid administration predicted low minute ventilation alarm criteria, with the conclusion that the ExSpiron could be used to adjust timing and dosing of opioids. Here, a blinded study was conducted at the Cleveland Clinic on 215 patients following major surgery. ExSpiron monitoring was started in the PACU and continued up to 48 hours on the hospital floor. The ExSpiron was able to risk stratify patients at risk for hypoventilation on the hospital floor. The study showed that 10% of the patients had hypoventilation during the last half hour in the PACU and then continued with hypoventilation on the floor. Surprisingly, maximum respiratory compromise was not in the PACU, but identified between hours 3 to 13 after surgery. The ExSpiron identifies patients in the PACU who went on to have significant hypoventilation on the floor, with continued episodes of hypoventilation for up to 48 hours. These patients were defined at risk during their PACU stay. This is one example of how nursing staff in the PACU may respond to low-minute ventilation alarms. This particular case is a post-op patient who had low-minute ventilation alarms with their first PCA dose while in the PACU. The PACU nurse stimulated the patient and noted that the PCA dose was set too high, at 0.2 milligrams of hydromorphone, which caused the patient to have significant decrease in minute ventilation. By following the facility protocol, the PCA dose was adjusted to 0.1 milligrams, allowing the patient to continue through their stay with no further signs of hypoventilation. Staff nurses can perform early and simple actions such as stimulation and repositioning. You can also consider adjusting the patient's medication regimen and encourage the patient to expand their lungs post-operatively, and ultimately consult with their physician team for further instruction should alarms continue. In this example, the patient had been suffering from a long-term condition and taking extensive pain medication regularly at home. The staff nurse could feel comfortable providing extra breakthrough coverage to help manage the patient's pain, all knowing that the patient was adequately ventilating even with these high doses of pain management medication. In this third example, you can see that the patient received oral opioids. This gastric bypass patient did fine with small doses of IV morphine, but had episodes of hypoventilation after their first dose of 2 Percocet. Note here that the low minute ventilation alarm was a result of low tidal volume as the patient had a normal respiratory rate. Several studies showed that over 80% of respiratory depression occurs with a normal respiratory rate. Respiratory compromise is more often associated with smaller breaths and low tidal volumes. After review of the American Society of Anesthesiologists closed claim database, it was revealed complications related to inadequate oxygenation and ventilation occurred 7 times more frequently in remote locations versus than in the operating room. The American Society of Anesthesiologists recommend that monitoring of ventilation be used in all anesthetic cases achieving moderate to deep sedation. Capnography was used by anesthesiologists in this study, but was often noted as erratic or unavailable. Our study suggests that ventilation monitoring could help optimize anesthesia, direct airway maneuvers, and provide real-time feedback for anesthesia and care providers. This case study is from a blinded randomized controlled trial in procedural sedation cases. The first patient on the top shows the patient bouncing between being over-sedated and in hypoventilation and being under-sedated, thus moving around, delaying the procedure. On the bottom, the patient using the ExSpiron and the ExSpiron's data. After the initial dip from the propofol induction, clinicians were able to titrate sedation to maintain adequate comfort and stillness while preventing episodes of hypoventilation. ExSpiron data can drive simplified protocols to help with risk stratification and patient triage for timing of discharge and level of follow-on care. In some institutions, it's mandatory that obstructive sleep apnea patients stay in the PACU for an extended period of time. In this sample flow chart, patients are risk stratified by the ExSpiron. If there are no ExSpiron alarms in a 30-minute time period and the patient has required no additional pain management, they are considered safe for discharge to their next phase of care, whether that be home or to the general hospital floor. If the patient has an alarm or requires significant pain management, the clock for additional 30 minutes is reset. This clock reset can be done for up to a maximum PACU stay of 2 hours. If the patient cannot clear the protocol in 2 hours, they are then evaluated for admission with ExSpiron monitoring on the hospital floor or another appropriate hospital location. This helps with throughput and timely PACU discharge. Treatment and care when responding to alarms, whether you're in the PACU or on the floor, is easy. One hospital system uses a chart like the one shown here to guide their staff on how to respond to alarms. The staff start by assessing their patient. If alarms continue, they implement incentive spirometry. This stimulates and helps reposition the patient, all while providing early lung recruitment. If alarms continue, call respiratory therapy or the physician care team to assess the respiratory status of the patient. Consider adjusting CPAP or BiPAP settings if the patient is receiving such therapy. Or consider initiating one of these types of respiratory supports, or deliver other appropriate therapy, such as albuterol. If the alarm occurs soon after an opioid or sedative is administered, call the physician team to adjust pain management regimens or initiate more aggressive interventions such as Narcan or reintubation if appropriate. In this 24-hour observational study, 250 patients were monitored in the PACU and on the general hospital floor with pulse oximetry, capnography, and the ExSpiron. Patients monitored with pulse oximetry had 2 to 4 false alarms per hour. Patients monitored with capnography had 12 false alarms per hour, and the patients monitored with the ExSpiron had only 0.01 false alarms per hour. When you have a nurse that has 5 patients with the ExSpiron, they would hear only 2 false alarms per week versus 200 false alarms per week with pulse oximetry and 2,000 false alarms per week with capnography. End-tidal CO2 and pulse oximetry monitoring were purposefully not utilized or removed by staff more than 50% of the time due to alarm fatigue in this study. This raises serious questions for the potential implication on overall patient safety. ExSpiron alarms are real, accurate, and actionable. 75% of the time, low-minute ventilation was addressed by stimulation or repositioning with or without incentive spirometry. Some other actions taken included CPAP, BiPAP, opioids, and changes to the patient's level of care. Let's now take a moment to review some basic features of the ExSpiron Minute Ventilation Monitoring System. The ExSpiron features include a user-friendly touchscreen, a rotating C-clamp for mounting onto an IV pole or bed rail, and has a 2-hour battery for use during transport. Easy startup with no requirement for calibration. The ExSpiron can be a standalone monitor or can be interfaced with capsule or Philips monitoring systems with subsequent transmission of data into any electronic health record through these systems. The ExSpiron also can be attached to any nurse call system without requiring any additional equipment or its resources. The ExSpiron disposable pad set is wearable for 24 hours before being replaced. If continuation of monitoring is indicated, the pad set should be replaced daily at the time of patient hygiene. The ExSpiron is now cleared for use in both adults and pediatric patients above the age of 12 months or weighing above 8 kilograms. Both the adult and pediatric pad sets stretch out and pull from a pouch to accommodate all patient sizes and don't show up at all on X-ray or CT scan. Respiratory compromise is frequent and is a leading cause of death in the hospital. It is a major patient safety concern and is a major contributor to the overall cost of care to healthcare systems. Importantly, it is considered that 60% of all respiratory failure can be avoided by better monitoring. The ExSpiron provides accurate, real-time monitoring for patients across the continuum of care anywhere within your facility. Please visit our website at www.respiratorymotion.com for further information. You can always reach our product support line in a time of need 24 hours a day, 7 days a week by dialing 781-609-7829. Remember, never miss a breath when using the ExSpiron.